Thank you, Dr. Rath, for the kind introduction. So, as a radiologist, it is always very nice to speak in a so-called non-radiology conferences, and I thank the organizers for giving me this opportunity. So, in the next 30 minutes or so, we will be like very initially for 5-7 minutes, I will be talking how a normal knee MRI looks like, and then what are the so-called specific and non-specific signs of osteoarthritis in the knee joint. And then there will be an interesting interaction based on the case-based discussion, which will be like each case will be a lesson why MRI is needed in osteoarthritis. So why we are talking of osteoarthritis so frequently and in so large forums? So as we all know, it is one of the most common disease which we come across, and we have seen this in, I think, for the last 2 days where all the discussion is on the osteoarthritis. It is definitely a big source of morbidity and disability when the patient comes to the clinic. When we are talking of imaging, so what is the role of imaging? So the clinical diagnosis is there in front of you of osteoarthritis when the patient walks to you in the clinic. So the imaging plays a role in the diagnosis, not as a primary diagnosis, but in cases where there is a confusion. Supposedly there is a young patient coming to you and clinically you think of osteoarthritis. So then you want to rule out whether actually it is osteoarthritis or something else which is going on in the knee joint. Definitely for the treatment planning, yes, the radiograph is the primary imaging, and we may need MRI to see for the severity, as it is like we need to see other structures which are not seen in the radiograph. Complications, this is one of the most important indication. I am not in favor of saying that the imaging helps in seeing the progression of the disease process, because the radiological severity is definitely not similar to what the clinical severity is. So I would not talk on this slide because just before this, I won't drag myself into the controversy, but definitely it is a disease of the synovium. And itis is being, so many people say it should be osteoarthrosis, but definitely there is a component of inflammation, so it is osteoarthritis as we call it. It definitely starts with a cartilage, so I used to wonder why don't we call it as, why do we call it as osteoarthritis, rather we should call it as chondroarthritis. In imaging, so the first imaging in any MSK thing, whether it is a tumor, arthritis, trauma, the radiograph is the primary and inevitable imaging modality. So ultrasound is a very important imaging modality coming to the arthritis, because me and Dr. Rath, we have combinedly did a study on like radiograph versus ultrasound versus MRI. And there are a few points which came out. The joint effusion, undoubtedly, that is one of the things which we don't need a MRI to see. Even synovitis. Similarly, for meniscal extrusion, which is one of the earliest signs of osteoarthritis, we can see in ultrasound. Osteophytes are very nicely seen. Even the trochlear cartilage can be well assessed. So these are the roles where the ultrasound can play. We don't need MRI for that, but definitely yes, MRI has a global imaging power where we can see the marrow, we can see the synovium and the other structures generally like meniscus and ligaments, and yes, the complications. So I won't go into the detail of the MRI protocol because it is not in the interest of this audience, but the two basic sequences which we see in MRI is T1 and T2. So the fluid is generally seen bright on T2 and it is darker on T1. That is how we differentiate. When we see a knee, definitely we'll have some amount of fluid and we can differentiate whether it's a T1 or T2 weighted images. So we are not using stir image, which used to be the dragging force for seeing any inflammation or any sort of injury in the knee joint. So stir and PDFS is the proton density fat suppressed image. So these are the two images where I will be showing you the images where the bright things are suppressed, like fat is basically suppressed, and you will see all the abnormal thing as bright. So it is not a umbrella term, but yes, it is. So contrast imaging is generally not required in osteoarthritis. We can do away with the contrast, but if we are using the contrast, we have to do some pre-contrast and post-contrast sequences, and there are some recent advances sequences which are being now developed. So I will just try to show you what the basic MRI looks like and what the basic structures look like in a MRI. So I prefer seeing an MRI in the first sequence which I see. This is an axial fat suppressed image, which is a PDFS which I told. Here you are seeing that all the like fat is like looking gray, and even the bone marrow is looking gray, though it is fat. So when I start with seeing the axial image, so here what we see is the patellofemoral joint, and this is what we are seeing, the cartilage, which should be quite uniform and gray. This is the trochlea. In this sequence, we always see the ligaments, menisci, and the tendons are dark, whereas the muscles are of the intermediate or gray in appearance. So as I scroll through the axial image, I am getting a overall like view how the joint is, what is the muscle looking like, whether there is any atrophy or not. Then I try to move on to the other sequences, which, like, this is a coronal sequence, again the fat suppressed image. Here you can see the menisci, the lateral and the medial menisci looking darker, bone is looking darker, and here we can also see the collateral ligaments, medial and lateral. And then I would like to move on to the sagittal, which I feel is a very important sequence to see the basic structures like the intercruciate ligament, the posterior cruciate ligament, the quadriceps, and the patellar tendon. So I have shown you three fat suppressed images, but I would definitely like to see a sequence where the fat is not suppressed. Like this is here, you can see the difference between this and this. Here the bone is looking brighter, so the bone fat is like bright here, and it is dark in the sequence. So in the non-fat suppressed sequence, I would want to see if there is any fracture or any lesion which is looking like dark in the fat, which is not fat, it is non-fatty lesion. So I generally prefer seeing these four sequences, and if needed, I do few extra sequences if needed. I will show you some examples as we move on to the cases. So basically, what do we want to see in an MRI in osteoarthritis? We will see the joint space, we will see the synovium, cartilage, subchondral bone, bone growth, like it is, whether it is sclerosis or osteophytes. We will see the meniscus, ligaments, and the tendons. So moving on one by one. So when we see the joint space, so there is a misnomer between asymmetric and non-uniform joint space. When we talk of symmetry, it is always when we compare with the other side. Many times people say there is asymmetric joint space reduction in the left knee joint or the right knee joint, rather than it should be non-uniform or uniform, because we are seeing a single knee joint. So here in this case, what we see is there is uniform, non-uniform medial side joint space reduction, though it is a asymmetrical if you see both the knees. Similarly, the same patient with the MRI, if you see, in MRI, the joint space comment is little like not very accurate, because when we do a radiograph, it is a standing position radiograph. So there is a weight bearing, and so we can see the joint space reduction. Whereas in case of MRI, it is a supine position, there is no weight bearing, so the joint space reduction may not be seen properly. As you see here, you can see there's the joint space by like the medial and the lateral is looking the same, though there is more fluid on the medial side. When we are talking of the bone growth, so there can be osteophytes and enthesophytes. So these are two different terms. So osteophytes are basically the chondral metaplasia. So there is a bone growth along the margins of the joint. As you can see, this is the radiograph where you can see small osteophytes. So there people also say there is tibial spiking. Actually, it is not a spike. The intercondylar eminence of the tibia is always a spike, but there you get the osteophytes. So instead of the tibial spiking, it should be osteophytes in the intercondylar eminence. So here the same patient, the MRI, you can see the bony outgrowths along the margin. So these are the osteophytes which are seen. The other patient, if you see, there is like this, in the inner margin of the patella in the lateral radiograph, you can see some bone outgrowth. This is an osteophyte, whereas there is some bone outgrowth at the attachment of the quadriceps, which is much well seen in the radiograph, the MRI, which is the enthesophyte. So there is two different terms, enthesophytes and osteophytes. Enthesophytes can be degenerative, though it is more commonly used for inflammatory pathologies. There is definitely cartilage destruction in the osteoarthritis. So if you move on from the left side images to right side images, there is more severity of the cartilage destruction. So here you can see there is a small defect in the cartilage, whereas there is a larger defect in the cartilage in the weight bearing region of the femur. Here the patella, you can see both the medial and lateral patellar facets, there is like the irregularity and fissuring of the cartilage. And in this, there is advanced like high grade cartilage loss. We are not able to see any cartilage in this medial aspect, where you can see the normal cartilage on the lateral aspect. When we come to the osteochondral complex lesions, so there will be cartilage as well as the subchondral bone, that is the bone just beneath the cartilage. So there you can get some marrow edema, which is seen as the bright in fat suppressed images. There can be a cyst, which we generally call as geode. So this we need to differentiate between cysts versus erosions. But when there is like combination of disease process going on, so it sometimes becomes difficult. So there will be osteochondral complex lesions in the osteoarthritis, where there will be cartilage as well as the bony loss. Synovial involvement can be, there you can get simple fluid like clear white fluid, as you are seeing in these two images in the patellofemoral ischius as well as in the joint space. Whereas in this example, you are seeing the fluid, there is some darker component within it, where there is a synovial thickening or synovial proliferation or synovitis. There are many types of meniscal involvement, whether it is a osteoarthritis or a traumatic knee. The common things which we see in osteoarthritis is, the most common thing which I told was the meniscal extrusion. So this is the medial meniscus, and you can see that there is a meniscal which is like moving out from the joint margin, and typically it will cause bowing of the medial collateral ligament. Another classical tear which we see in osteoarthritis is a vertical tear or a radial tear of the root of the medial meniscus. You are not able to see the continuity of the medial meniscus. The horizontal tear of the posterior horn of the medial meniscus, this is also a degenerative tear, as well as the oblique tear of the anterior horn of the lateral meniscus. So generally, like in the broader term, the horizontal tears are degenerative tears, whereas vertical tears are traumatic tears. But that is not always true. We do see degeneration in the ligaments and tendons, where we'll see it should have been the bright, like black signal of the quadriceps and the patellar tendon, but we are seeing some intermediate or gray signal. So this is what we call as the mucoid change. So previously we used to call it as mucoid degeneration, but now we are seeing this to happen in early, like young patients also. That's why we have started calling it as mucoid change rather than mucoid degeneration. This is a classical example of a ciliary streak appearance of anterior cruciate ligament, that is the mucoid, diffuse mucoid change of the anterior cruciate ligament, and this may advance into cystic areas within the ACL, and then it can lead to further tear. There are various types of cysts around the knee joint, like the ganglion cyst, which you commonly see at the attachment of the gastrocnemius and the posterior aspect of the femur. You can see Baker's cyst, and in Baker's cyst you can also see some bodies which are seen within it. So we used to call it as loose bodies, but now the term specifically is used as osteochondral bodies or intra-articular bodies, because these are not always loose. So many a times they are attached to either the capsule or the synovium. So it is better to use that intra-articular bodies rather than the loose bodies. You can also see some prepatellar bursitis, where there is swelling. This is definitely not an indication for MRI. Ultrasound can well suffice this indication. So like I'm trying to show this from two advanced imaging like which we do. One is the cartogram or the cartilage mapping or cartilage imaging, which is an advanced software which is used to see the cartilage. So this is all the technical like values which are being given here. But just for your understanding, mostly when you see red thing, it is like burning. So this is the loss of articular cartilage. The green and blue are the normal articular cartilage. This is something what has come out to be a 0 TE. This is not a CT image. This is an MRI image. But in this advanced sequence, the bone can be seen as a CT. So we can, to some extent, avoid doing a radiation CT procedure. So wrapping up with the common findings which we see in osteoarthritis is a joint space reduction. It should be non-uniform rather than asymmetric. We see osteophytes, we see cartilage loss, osteochondral lesions, meniscal tear, mucoid change in the ligament and the tendons, and the common cysts. So now we'll move on to the more interesting part where I'm more interested in the interactive session is the case-based discussion. So let's now see how, what we have learned from the last 10-15 minutes. So this will be a poll-based thing where I think all of you present here have downloaded the Slide-On app. Yeah.
So even through simple Google Chrome, you can go to slido.com. Sir, previous slide, can we go? Yeah. You can scan this QR code if you want to, or you can just go to slido.com. They will ask for a code and we can write SOAR. The hashtag is not needed. We can just write SOAR. We'll take here, I think, 20-30 more seconds, so maximum participant can join.
So can you know how many participants have joined?
Yes, I think next slide will show it.
So I would request everyone to try one of the options.
Okay.
Can start?
Yeah, yes.
Okay, so this 56-year-old male who is a known case of osteoarthritis, because this session is of osteoarthritis, all the cases which I will be showing is a known case of osteoarthritis, but the chief complaint will be different from what generally a patient comes with a OA, knee. So this patient came to the doctor who has been treating this patient for long with acute onset pain in the medial aspect of the knee joint. And these are the two images. This is the fat suppressed image, and this is a non-fat suppressed image. This is a T2 and this is a PDFS image. So this patient had acute pain in the medial side of the knee. So this is the medial aspect of the knee joint, and this is the lateral aspect. So these are the options. So as you start thinking on the images, I would like to give you some hints. So this area is definitely looking abnormal in both the images as we compared from the lateral femoral condyle, and that is the area of pain. So this is a brighter area which is basically marrow edema. So that marrow edema is causing the pain. But what is the cause of the marrow edema here? So is it like the inflammatory phase of the OA? Is it because of the meniscal acute tear? So we are not seeing the meniscus over here. So, but do you think that this meniscal tear is causing the acute pain? Or is there any subchondral fracture? Or is this a medial collateral ligament tear? So this is what the medial collateral ligament is looking like. Can we see the pool? So 58%. Okay, nice. So let me know when we stop. Okay, so 58% says that is a subchondral fracture. So can anyone say where the fracture is, like who have among the 59%? Very nice. So here what you see is a dark line which is seen just beneath the articular cartilage, the subchondral bone, and the epicenter of the marrow edema is just beneath that. So, and that is also nicely seen in this non-fat suppressed image. So there is a small subchondral insufficiency fracture which has caused this marrow edema, and then there is acute pain. So the audience is quite intelligent. Okay. So the next case is this is a quite young female with early osteoarthritis and presented with intermittent locking of the knee joint while walking. And she has felt this over a couple of weeks while doing a morning walk. And then she came to the doctor complaining, and the doctor examined that actually, yes, there was this locking. So is this locking because of some synovial proliferation which has happened in the inflammatory phase of the OA? whether there is a meniscal acute tear or this is a subchondral fracture, again medial collateral ligament tear. So this is again sagittal image where we are seeing the posterior cruciate ligament. This is the sagittal image, the next section. There is no marrow edema as such, and there is some physiological amount of fluid which we are seeing. Okay, that's good. But I am here just to show what the clinical findings are correlating with the imaging. Okay. So this image shows what is something called as the double PCL sign. So this is a bucket handle tear of the medial meniscus. We are seeing the normal posterior cruciate ligament, and along with that anteriorly we are seeing another similar looking structure which is the flipped medial meniscus, which is flipped into the medial aspect of the knee joint. So this is a bucket handle tear, acute tear of the medial meniscus. But what is this image showing? So whenever we see a bucket handle tear of the medial meniscus, we should always try to see the anterior cruciate ligament, because generally medial meniscus bucket handle tear is not a solitary or independent finding. It is most of the time is associated with the anterior cruciate ligament tear. So here we should have seen a similar continuous structure as we see the posterior cruciate ligament with the anterior cruciate ligament, which we are not seeing. So there is a complete tear of the anterior cruciate ligament along with the bucket handle tear of the medial meniscus. Okay, so the third case, 67-year-old female with an advanced osteoarthritis. She has recurrent knee swelling, and she has recent 2 episodes of synovial fluid aspiration, but still the swelling used to come back very frequently after the aspiration. So from these 2 images of the MRI, can we find out what is the cause of the recurrent swelling? So this is the axial image, fat suppressed. This is the sagittal non-fat suppressed image. We can see there is features of osteoarthritis where we are seeing that there is some subchondral bone changes in the patella as well as in the tibia. But apart from that, what we are seeing is there is like bright thing which is there in the joint, that is the synovial fluid. So is this simple synovial fluid that is causing the recurrent swelling, or is there something else?
That is the limitation of clinician.
Yeah.
Mullah ki daud masjid tak ki hai.
Okay. So PVNS, now the term has been replaced by tenosynovial giant cell tumor. So the thing is, in PVNS, what happens, like we would see, not always, but we'll definitely see some erosions in the bones, which is not seen here. These are the osteochondral lesions of the osteoarthritis which is seen. We are definitely seeing some frond-like projection in the synovium. This is the synovial proliferation. But this is the image which is a T1 weighted image, where because the fluid is dark here, as I told, fluid is bright in T2 and dark in T1. But within that dark fluid, what we are seeing is a frond-like projections which is bright. So the bright thing is fat in the joint. So in case of pigmented or that PVNS or tenosynovial GCT, it will be all dark because there is all hemosiderin deposition. So this is a case of lipoma arborescens. So many times when we do get the patients with swollen knee, so there are few differentials which we can think of. One of them is a lipoma arborescens. And imaging definitely helps this over the clinical assessment. Okay. So next, similar case with a advanced knee OA in a 61-year-old male, and who had difficulty in flexion and extension of the knee, and again this patient had intermittent locking. So the axial and the coronal image, which we can see, there is definitely advanced osteoarthritis. There is complete loss of the articular cartilage. There are large osteophytes. There is also some bony destruction along the lateral aspect. There is complete like complex tear of the medial meniscus. We are not seeing the meniscus at all. There is some extrusion here, and some mucoid change which is happening in and around the knee joint in the ligaments and the tendons. Apart from that, like anything striking which is seen? Okay, can this be again like PVNS, or the locking is being done by some osteochondral bodies, or it is just the osteochondral lesion or the chondrocalcinosis? So in chondrocalcinosis, we will be seeing dark signal in the cartilage. So we are not seeing any dark signal in the, whether in the patellofemoral joint or in the femorotibial joint. The cartilage, there is complete destruction here, and here the cartilage is looking normal, but there is no darker signal. What additional finding which you are seeing is something which is there, which should not be seen in the patellofemoral recess. So this is what is called as the osteochondral body or intra-articular body. So, but the actual picture of this patient is what this is. So very nice looking picture, but definitely not nice joint for the patient. So there are like necklace-like osteochondral bodies which are seen in the patellofemoral joint, and is all whole of the joint is full of the osteochondral bodies. So these osteochondral bodies are basically causing the locking of the knee. Another case with again swollen knee, and but this is a fairly young male patient, and on examination there was a clinical suspicion of osteoarthritis, but still there was some suspicion whether yes, is so young patient, should it be osteoarthritis or not. Radiograph was done, and there was still a like 50-50 chances whether there is because there was no classical signs of osteoarthritis seen. So the MRI was advised by the clinician, and this is what we did. Here I am showing you like few extra sequences or other imaging modalities, imaging sequences. So this is axial fat suppressed, this is non-fat suppressed. This is what is called as the gradient image, which we do for to differentiate whether there is a calcification or blood in any soft tissue or bone. And this is again a non-fat suppressed large field of view knee joint. So yes, we are seeing definitely there is joint fluid, which is like much more than what we expect. There is some cartilage loss in the trochlea, which is also seen here, there is defect. But we are not seeing any classical feature of osteoarthritis. There is no osteophyte, there is no subchondral bone destruction, but there is something happening within the joint fluid. So people have learned from the previous case. So this is what we are seeing, the dark signal within the synovial cavity. So this is all looking black in this sequence. Either it should be blood or calcification. So if we see it is looking black in all the sequences, this is a T2 sequence. If it would have been blood, it would have been seen bright here. If it would have been calcification, it would be like here within that you are seeing some bright area which should not have been seen. And here this area, what is looking like, it is like the synovium which is all like thickened up. It is not looking like separate osteochondral bodies. So this is a case of pigmented velonodular synovitis. In advanced cases of PVNS, you will see more large erosions, but then in those cases you won't be seeing osteophytes. That is a clinching differentiating feature between osteoarthritis and a PVNS. So next case, again advanced osteoarthritis, but this patient came with very recent onset of pain in the lateral aspect of the knee joint. And this MRI was advised because definitely there was a thought that there is not only osteoarthritis which is going on, there is something else which is happening. But the clinical diagnosis was not done very definitely, so MRI was done. So this is a lateral image, coronal, again axial, and the sagittal. We are seeing large osteophytes. The signs of osteoarthritis are definitely there. Yes, there is also a osteochondral body here, but the pain is more on the lateral aspect. This is the lateral aspect of the knee. This is the fibula which is seen, and this is the tibia. So this is the proximal tibiofibular joint. Very nice. So what we are seeing here is there is abnormality in the fibula. There is large marrow edema which is seen, but within this we are able to see some geographical or serpentine pattern or double rim sign which we classically see in avascular necrosis. This is much nicely seen in the non-fat suppressed sequences. That is the importance of non-fat suppressed sequences or the T1, T2 sequence in the knee joint MRI in OA. So in this case, the patient definitely must have the history of some steroid intake for long, and there is a development of osteonecrosis in the proximal fibula, which was causing this pain for last 2 weeks. 45-year-old male, young, with history of, this is an international patient who came to us with history of surgery for trauma some 14-15 months back. And he was not very well aware that why multiple other interventions were also done in the knee joint, and there were no clinical records which were available with the patient. And this patient came with fixed extension deformity. The patient was unable to flex the knee properly. So the radiograph is withheld. I am showing you the MRI. We have also done the radiograph. So what we see here, there is here what we are seeing is quite uniform joint space reduction. Both the medial and lateral aspect joint space is uniformly reduced. And there is some marrow edema here, the cartilage is lost, yes, there is some darker signal in the cartilage, which is also seen in the lateral aspect of the joint. Okay. So when we differentiate between purely inflammatory versus infective versus osteoarthritis, yes, the joint space reduction is one of the primary thing which we need to see. So because there is a uniform joint space reduction, we can think of inflammatory or infective arthritis. As there was some surgical intervention done, this is more in favor of infective arthritis is true. I'll show you the radiograph here. So this is the right knee joint, where you can also see the evidence of osteomyelitis in the shaft. And for this, there were multiple drainage procedures which were done. And there is quite a uniform sort of joint space reduction. But currently, the flexion, the patient was unable to flex was because of the chondrocalcinosis which has developed in the knee joint. So its chondrocalcinosis was also there here and also in the patellofemoral joint. So this is a secondary to the infective arthritis which is there. So it is not that chondrocalcinosis will always be there in the calcium deposition disease or the CPPD or something. It can also happen in the infective arthritis. So the last case is the one which I shared for the pre-workshop with everyone. I think most of the people have seen it. If not, we'll again discuss it right now here. So this is the last lesson which I would try to tell you about why we are doing MRI in the osteoarthritis of the knee. So this was the 65-year-old male who came to the orthopedics OPD with complaints of pain in both the knee joints on walking and climbing downstairs since 2 to 3 years. And there was intermittent episode of pain at rest as well. And he was taking on and off anti-inflammatory and some vitamin supplements, and there was symptomatic relief. But currently, he came to the clinician with a pain, increase in the swelling, and which was for last 2 days. Local examination was done, which shows there was some effusion, and then the patient was sent for the radiological evaluation. Based on what the clinical input was and what I saw, was radiograph was first done, and then MRI was proceeded because radiograph was we wanted to see something more. So what is the sequence based on the last 7-8 cases which I showed you? So can you guess what is this sequence basically? So the marrow is looking bright, the fluid, so this is what we are seeing, this is the fluid joint effusion which is looking gray or dark. So it is a So we can get the pool? No? Okay, fine. So this is a basically coronal T1 weighted image because the fluid is looking darker. So one of the basic thing which you should remember is like generally fluid is dark, brighter on T2 and darker on T1. Okay, the same case. So what is happening to the joint space? So the learning is whether it is a uniform and a non-uniform joint space reduction. So it is a uniform joint space reduction. Okay, we are getting the pool. So there is definitely uniform joint space reduction, and there is also some subluxation of the joint along the medial aspect. Okay, so what is this blue and the white arrow indicating? So here there should have been a normal cartilage which should have been uniform. So there is complete cartilage loss here, and this is what you are seeing is the patellofemoral recess. This side there is clear fluid, but along with that what we are seeing is there is synovial thickening. So there is synovitis also happening in this joint. So there is uniform joint space reduction and there is synovitis. Along with that we are getting some osteophytes as well. Okay. So what are we seeing in this subchondral bone? What is happening? So there is complete loss of the articular cartilage. And then beneath the articular cartilage, we are getting some lesions. So these are definitely subchondral lesions. But what are these? So these are definitely small erosions which we are not seeing as a clear cyst within it. So we can see there is variable signal which is seen. In some we are seeing fluid-like signal, whereas in other you are getting some intermediate signal. So there is the destruction pattern of the subchondral bone is not quite uniform. The margins are quite irregular. So these are subchondral erosions which are happening. So among this subchondral erosion, there is something else also which we are seeing, which is a much larger one in the same subcortical subchondral bone, which is there. Here you are seeing the margin is little sclerotic and quite defined. There is definitely some marrow edema. The edema is seen as dark in the non-fat suppressed sequences. So yes, so this is a large subchondral cyst or a geode which was separate, looks separate from the previous image which I showed of a erosion. So there is a combination of uniform joint space reduction, cartilage loss, erosions, osteophytes and subchondral cysts. So we are getting the picture of osteoarthritis along with there is which is going against osteoarthritis, a uniform joint space reduction. So what can I get the last? I had one more radiograph. No? Okay. So I would just 1 second. It is not there. So the radiograph clearly showed that there is like on one side this is the left knee joint there was uniform joint space reduction, whereas on the right knee there was non-uniform joint space reduction. So this was an inflammatory arthritis which was going on in the background of osteoarthritis. So that main teaching was from these cases that when the MRI is not the primary imaging which needs to be done for osteoarthritis. It is always done when we are suspecting something else or when the diagnosis is not very sure. Like the examples which I showed, like when there can be a fracture subchondral, there can be some other lesions, there can be osteochondral bodies which are not sometimes seen in the radiograph, or there can be some other marrow changes which is happening and which is not very evident on the clinical examination or the radiograph. So thank you very much for this patient hearing. The lunch is ready for you, I think. So if someone is interested, you can go through this whole section of a skeletal soft tissue imaging. This is from my book, which I am one of the associate editors. The textbook of radiology by Sutton. This is supposedly the Bible of radiology, and I am privileged enough to have like me as one of the associate editors. And coincidentally, the knee chapter is also written by me. So if anyone comes across this book, try to read it. This is a complete whole section of musculoskeletal imaging in this textbook. Thank you.